right.
Okay. For all those that are out there virtually, I'm sure people will be rolling in over time. And what this talk does is allows me to go through some very important questions and questionnaires. The genesis of this talk is really one to try to help the physicians find a way to document what they're experiencing with the patients and what the patient's complaints are, which can help them in supporting their opinions and their reports. So I usually have to go through some disclaimers. I'm just going to go through that real quickly for you. I did not say what you thought I said. You did not hear what you thought you heard. Artificial intelligence is no match for natural stupidity. Hopefully I'm not going to be too stupid here, and I can give you some good ideas. A lot of the comments in here come from the guide's book, Evaluation Functional Capacity. I don't get royalties for that, but I do have to do my financial conflicts of interest, which are always required. So that happens to be with the AMA Guides books. So that's the AMA Guides Evaluation and Injury Causation book. This is the Workability and Return to Work book. This is the Guide's 6th edition book. And then this is the Guide's Disability Benefit Systems book. So again, I keep my day job. I don't make a lot of money from those, with full disclosure. I also get paid by MD Guidelines to review the database from time to time. Again, I don't think that something's going to be come up today. And sometimes I make more money by actually working than giving talks. So that's a conflict of interest for me. Here's a picture of some of my boys at a certain point in time. I also owe them acknowledgments along with co-editors, the staff of AOS, and everybody else. Okay. Can we avoid the unforeseen? Okay. So every time you go to the literature, there's a whole bunch of information about questionnaires, right? And you look at these lists, you go, oh my gosh, there's so many pain questionnaires. Where do you start? What do you do with them? Which one's the right one for me? And most importantly, what do I want to use in my practice to help me, right? And that's an important thing I want you to keep in mind, that this is about helping you, helping make your reports substantial, credible, to protect you in case you get an interrogatory, in case you get a deposition, to have a basis of forming and supporting your opinion, right? There's also questionnaires for the spine, right? And every time you look in the literature, they talk a lot about biopsychosocial. So you're going to hear that a lot, right? About all the studies that show that a lot of pain complaints, a lot of symptom reporting, a lot of reasons that people seek workers' compensation, disability, private injury, all those kind of things have to do with other factors rather than just the mechanism of injury, right? Mick Sullivan has some biopsychosocial scores, which are also very helpful and ones that you could think about and look at. And there's also screens for malingering, right? Which is a very powerful term, fraught with a lot of implications. And so I tend to tell people to be careful in using that when they're doing evaluations of patients. But here's an example, right? PTSD. Everybody knows about PTSD, heard about it, right? And there are questionnaires for that, right? That is something that we're not really covering today, because we're really covering people who have injuries and pain complaints, and then how do you bring that into your reports to really make that helpful and supporting your opinion, right? And there's certainly a lot of studies that looked at all kinds of different mechanisms to add up somebody's distress, somebody's concerns, somebody's difficulties. And when you add all together, you do studies like this, you see that when they're looking at why do people stay out of work, why do people have claims, why do people report certain symptoms, what you see is that you see this clear pattern where the majority of reasons have nothing to do with the mechanism of injury. It has to do with the number one predictors of when do you think you'll go back to work, asking people what they're feeling, right? There's another study, Optima, right? And it said, look, if you're going to try to figure out who's injured, why are they injured, why are they not getting better, why did they not go back to work, right? You're going to see these types of criteria. And this is their expectations, their belief systems, and how they review all the things that have happened to them and what it means to them. Not necessarily the mechanism of injury, right? So this becomes very important in these biopsychosocial models, right? There are well-known questionnaires that look at this for presenteeism, absenteeism, right? So presenteeism is before people are even absent. Some things that are already operating that's going to make it more likely that they're going to have trouble in the work environment. And there's a whole bunch of questionnaires that look at that for different areas, right? And what happens if you give somebody one of these questionnaires? What happens if you identify somebody that may be having troubles? What do you do, right? Well, we certainly know that if you know something's operating, if you intervene, it can make a difference, right? Winwood showed that there's all different domains of resilience, right? And how patients handle their injuries. So you could imagine that if you have somebody that has an injury, doesn't seem to quite fit, doesn't seem to be consistent, doesn't seem to have the normal outcomes, and they're claiming limitations, difficulties, which seem to you to be out of proportion to the mechanism of injury, out of proportion to what your normal clinical experience tells you, then they're saying from this literature, there's ways of thinking about people, their resilience, how they handle things, and what can we do about it. And when you look at questionnaires, NIOSH has criteria, right? They have to be practical, brief, valid, available, lack confounding. In particular, they have to be written to a certain educational level, usually about 8th grade, right? So you really got to keep it at a low level, right? So how do we get to a legitimate questionnaire? How do we ask for these questionnaires that are going to tell us what we need to know to substantiate our opinions, to make our reports credible, to help us when we're in the middle of a deposition, an interrogatory, when we're trying to justify our opinions on somebody's impairment, ability to work, right? All right, so first, how did I get in trouble? Well, I had somebody came into my office with back pain, longshoreman, right? And so the claims person had called me up and said, look, Mark, this gentleman says he can't go back to work, but we don't know much. He's been treating with some physical therapy. And I saw this guy and I said, okay, I'm going to show them how this gets done. I'm going to do a careful history, careful examination, and I was going to document everything, right? And so this guy said, oh, Dr. Hyman, I like your office staff, and everything's great. And I sent him into some physical therapy, and I was seeing him back every 2 weeks, and I was documenting he was 30% better, 40% better, 50% better. He said, I'm great, I'm great, I'm great. You're the greatest staff. And then I finally said one day, remember, this was a Thursday, by the way, I'll tell you why I remember that. And I said, look, I think it's time. And he said, time for what? He said, time to go back to work. And he said, what do you mean? And all of a sudden I started to get very nervous. I said, well, you know, why have we been treating you? And he said, well, it just turns out that Tuesday was the worst day I've ever had. So all of a sudden, everything I thought I was documenting, thought I was dealing with, turned out not to be true. And I said, there has to be a way where you and I can use some clinical experience to try to understand these pictures and what they look like. And this actually comes down to some of the stuff that you can even read from Malcolm Gladwell's book, The Intuitive Blink, right? Which is really based on Kahneman Tversky's Nobel work on System 1 versus the System 2. Now, what this is, stay with me, listen to this very carefully, really important. When you and I go through training, we start learning about how to evaluate patients. What does it mean? What does it signify? And we start to see patterns. And we go through that laborious process. That's System 2. That's where we're doing learning, integrating, putting things together. But as we see more and more patients, as we keep practicing longer and longer, we start transitioning to a System 1 where things become more automatic. And there's ways of looking at patterns so that we can see the patterns that tip us off that there might be something operating here, right? So what we do is walk you through some questions and questionnaires that you can think about putting into your practice to try to help you and guide you into what things you may or may not want to do, right? So let's take a look. First of all, everybody does this, right? You ask people, what's your job title? How many years were you doing duties? Give them a questionnaire. Sometimes you'll get this. Look at this. Look, 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 look. So here's the job title, years of position, and the duties, right? Now look, I happen to pick this person because look, medical front office, medical record in the office, right? So you know these positions. Yet look at all the heavy written descriptions, right? That's starting to tell you that there's something going on. If you just say, what's your job and how many years were you there, you're not going to get this. Give them a questionnaire. Let them describe what's operating and let them put it on paper, and you start to see this pattern. Look at this. CNA, right? So those are the certified nurse assistants, right? Now, you've been in nursing homes before. You see what some of these folks do. It's there for a year and 2 months. But look at the job descriptions. And what's the most worrisome thing here? Sure enough, it's the arrow, right? You go, and here's page 2. This person is describing themselves in overly specific ways, very verbose, heavy on trying to bring you into their identity of their illness, how much they've been oppressed or hurt. It starts to let you see a pattern, right? Give them a questionnaire. Let them write it down. Let's see what happens. When you see a TMI, you know that you're into trouble, right? Look. I want to show you this one. Look at this. Look. Okay? Here's patient SS, okay? This person took 5 hours to fill out my questionnaire. That alone tells you right there you're in trouble. Give them a questionnaire. Let them sit in your waiting room for 5 hours. In the meantime, you can take care of other patients, right? And here's page 1. This is a person who worked in a kitchen, right? So you can see already, listed duties on the side, right? Here you go. This is page 2. All the server duties. I take food, I tabulate food, I keep all the workers, I silverware, china, and stuff, right? Look at this. Page number 3, right? Kitchen manager, supervisor, manual kitchen inventory, deal with that, right? What do you see there? What you see is somebody that's really talking about so many different criteria of things that bother them, things that they feel about, right? Give them a questionnaire. Don't just ask them what their job is. Tell them, here, put it down on paper. And if you start seeing people giving you this kind of response, you start to see a pattern, right? This is someone that's starting to show you some somatization, symptomification, right? These are the people that are going to go on to delayed recovery, chronicity of illness, right? We have to keep that in mind, right? Look here. This is patient 615. She had a PhD and she only worked for 3 months, and she had 4 back surgeries, which, no surprise, did not work, right? She worked as a med tech, right? So look at all the circles, the boxes. It's, I'm dying, help me, reach me, right? And once again, we've got an arrow, right? This is not enough space. We got to go to the next page, right? And put down all the different criteria of things that bother us, right? This is not normal. This is someone that is having an overreaction. This is somebody that has taken on an illness identity. This is not the kind of person that you want to do surgery on. This is not the kind of person that you just want to say, go to regular physical therapy. This is not the kind of person you say, there's nothing wrong with you, go back to work, right? This is the kind of person that the red flags have to go up, and you have to know there's something going on. How do you get this? Give them a questionnaire, ask them, right? Next, on the questionnaire, we all do this, right? Job descriptions. We want to know, why did they have a certain injury? How often did they do things? Could they go back to the job, right? And give me a description of their job duties, right? So when you do that, here's what you get. Now, this is a patient who's a construction job site supervisor, right? Now, I want you to know something. This person, his job was, he would take plans, put them in his pickup truck, and he would drive to different job sites. He'd unroll the plans on the trunk of the hood of the car, go over with people, walk the site a little bit, roll it up, put it in, go to the next site, right? How is it possible that this person constantly, that's about confidence, that look, Neil gets a star, repetitive feet. I want to make sure you know it's both feet, not just one, right? Checking up both boxes, right? This is physiologically impossible. You're entertaining somebody that's doing a dance for the Cirque du Soleil and bending and twisting everything different directions all at once. It's not going to happen, right? So this is the kind of warning that you're getting, that there's a pattern here, that this person is describing things in excessive terms, right? Next, give them a questionnaire. Ask them about lifting, right? You and I got to do this anyways, right? We got to know, could they have reasonably injured themselves? Could they go back to that work, right? What does that show? Well, here's our CNA, the woman working at a nursing home. I mean, all of a sudden, you're telling me that this CNA working at a nursing home, what is she doing at the nursing home? That she's constantly with the grade 100? Are you kidding? I mean, is she bench pressing the residents, right? There's just no chance. This is not happening, right? So it tells you that there's a pattern, right? Look at this, right? This is the construction site supervisor, right? We talked about that. I told you. I asked him specifically, what do you do? And he told me about driving, unloading things. But when it comes to documentation, right? If you have it on paper, you can start to justify your opinions, support your analysis, explain your reasons. You can say, here's what he wrote down, but I know that that's not true. Therefore, some of his history is unreliable. His physical examination can be unreliable. Therefore, my analysis is based on the normal physiologic mechanisms, right? I once had, on this questionnaire, by the way, I put this as a reminder, motorcycle officer, okay? Now, police motorcycle officers do great service, but usually I find motorcycle officers in two locations. They're either on the highway looking at you or they're in a donut shop, right? So this gentleman was riding a motorcycle. I got to this, and he said he constantly did all this lifting. Now I said, you know, look, Mr. Officer, sir, I understand that you put this down, but please forgive me. You know, I think there's a lot of time where you're sitting, looking, doesn't seem like you can be constant lifting. He said, well, you know, Mark, the motorcycle weighs 900 pounds, and when you're turning the motorcycle, it's like you're lifting it. Okay, so, you know, I'm not sure that's what is intended by the language, but what I do hear, what I do see, what pattern is emerging is this gentleman's not interested in going back to work. He's not interested in getting better. It's the kind of person that has taken on an illness identity, is trying to justify something for a claim, right? You need to know that. Get the documentation. Give them a questionnaire. Ask them the questions. Let's see what they respond. Okay, next, work history. Okay, now, you and I do this anyways, right? We always like to get a work history, right? And say, okay, were you hired anywhere near? If it's somewhere near this period of time, then you say, okay, did they hire you with any limitations? Or did they hire you to come work full? If you did that, you need to know that, because you can say, well, look, you may have gotten injured, you may have a problem, but it's clearly not that bad, right? And concurrent work, you have to drill down on this. Many times I say to people, are you working anywhere else? No, no, no. But you have to ask, look, are you working with a cousin, a brother-in-law, weekends, something like that? And sometimes you'll get the history that they're helping out, mowing lawns, painting buildings, whatever it is. You got to ask the questions, right? And prior work history. This becomes a very important area, right? Because prior work history can be very helpful. So let's take a look at some of this, right? Okay, so here's somebody that starts putting in their work history. Notice the descriptions of all the different tasks. Notice how critically important it is for them to really emphasize their words, to circle things, right? That's telling you that there's somebody that's showing you a pattern where they're feeling that they're being put upon, that they've been injured, they have significant difficulties, right? Take a look at this. This is very important. Now look. So this is a patient GG that work stressed her out. Now look at her work history. 90801, 898-1200, 299900, 1297-299, 797-8977. You see that? What you see is a history of frequent job changes, short job durations. This pattern is a predictor in the medical literature of patients who have difficulty operating in the work environments. The reason for their problem has nothing to do with their spine. It's in their mind, right? These are the people that have difficulties, and when they have difficulty, the problem becomes you. the employer, the doctor, the physical therapist. It's not them, right? And so this is an important concept. If you see a history of frequent job changes, short job durations, these are the people that go on to have problems with somatization, symptomification, delayed recovery, chronicity of illness, right? Keep those things in mind, right? Give them a questionnaire. Get that work history. That'll help you. Okay, next. Always, I like to ask the questions about exposures. Again, I'm not necessarily saying this is your area, but certainly keep in mind that sometimes people could have exposures which could cause some different symptoms. Give them a questionnaire. Let's see what they say. It doesn't have to be your area. Okay, next. Family social history. Okay, now you and I were always trained to do this, right? But the most important thing on this history is you have to look at it carefully. Why? Because on the questionnaire, I will usually ask a question about a personal history of marriage, children, and it's the most important question. Do you have a past history of a poor childhood rearing or abuse? Any difficulties in family relationships? Ask the question. Why? Because in the medical literature, this question, a past history of abuse, is the #1 question that predicts patients who go on to have somatization, symptomification, delayed recovery, chronicity of illness. These are the patients who file claims. These are the patients who have trouble in the work environment. These are the patients that you need to know about. Because if you have somebody that has a past history of abuse with vague symptoms, the MRIs don't look that significant, the exam's irregular, don't, whatever you do, operate on these people, and certainly keep in mind that they're going to have a filter of how they see the world, how they see their illness, and how they're going to interpret it, right? Next, I've given this lecture for years. I've tweaked it through years, depending on the medical literature, but something has been constant. I have almost always had a patient recently that had a past history of abuse. And by the way, a lot of times they don't talk about it, right? Sometimes, for example, I've had patients where in the family history, they say, father deceased, age 54, I don't know why, or something like that. So sometimes you have to drill on that, right? I say, well, you know, that's a bit of a young age. Did the doctors ever tell you why the person ever passed away? Said something about his liver. Oh, you start to get the opening. Oh, and I will say non-directly, well, you know, sometimes people have liver troubles, could be because they were drinking too much. By any chance, did that ever happen in your home? I said, well, yeah. And then you start getting to, well, was the home ever somewhat verbally difficult where people were yelling or shouting? Yes. By any chance, was there any physical hurting, any touching that was inappropriate, right? And you start to unroll this. You get this from the history. You have to ask these questions. You have to see if it's operating because it's very common in our world. I'm not saying, by the way, that you and I are psychiatrists, right? We're not. What I'm saying is you have to know these things are operating because it makes a difference on how you interpret the results, what impact it has on their examination, and what you're going to do for them or recommend for them, okay? Now, review system, okay? You and I were always trained to do review systems, correct? And it's just a kind of standard form, right? Well, what happens in the claims context, right? Here's a review system, right? This is a dishwasher who's got stressed out. Look at that. Check marks next to everything, right? A markedly positive review of systems is an indication of someone who's got a somatic symptom disorder. These are the people that go on to have these difficulties, right? Give them a questionnaire. Let them document it. Put it in your reports. Put a copy in there, right? And just say, look, there's some over-reporting of symptoms, right? It's going to help protect you. It's going to make your reports more credible. It's going to make it more understandable when you justify your opinions. When you say, don't do surgery. When you say, the outcome is not as bad as they say. When you say, the objective findings are greatly disparate from the subjective complaints. And because I see these markers that are subjective and unreliable, I have to rely on the normal pathophysiologic mechanisms, right? What are you seeing? You're seeing the somatic symptom disorders, and the prior nomenclature was somatoform disorders, and there's all different terms that have been used for this throughout the years, right? And what's the criteria? Okay, so look, there are actually explicit criteria put in the DSM-5 that talk about the somatic symptom disorder. So you can start to see how it's described. What does it mean? How often do they report the symptoms, right? And there's different types, right? Look at this. You've heard of some of these before. A conversion disorder, factitious disorder, psychological factors affecting medical condition, right? These are terms you've heard before, right? And I'm not asking you to diagnose them. I'm not asking you to treat their psychiatry. I'm not asking you to be a psychiatric expert, right? I'm only saying what is operating, right? And if somebody questions you, well, my client said this, 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 and you said that there's nothing wrong with them. You can say, I didn't say there's nothing wrong with them. I said, here's the normal outcomes from that surgery. Here's what the physical exam suggests to me. Here's why I think their impairment rate is this, or they can work, or something like that. But I do think that they're over-reporting symptoms. And this might be a somatic symptom disorder. And that's something that's influencing their opinion, right? Here's a questionnaire, right? So if you think it's operating, you want to give them a questionnaire to document your opinions, to support your substantiation of what you're thinking, then here's something you can see. And you can use that to put into your reports or to use in guiding you on how you interpret what to expect from these people, right? Now, this may come as a surprise to you. Sometimes people are lying. Lying, though, requires a whole bunch of things, right? First of all, lying requires the deceiver to keep facts straight, believable, and withstand scrutiny, right? And so that means that if somebody's fabricating things, they have to keep giving a consistent history, a consistent way. Well, it turns out that oftentimes people that get into this, unfortunately, aren't able to do that. And so what you'll see is discrepancies in the records. You'll see discrepancies between what they tell you and what you see in the records. You can see discrepancies between one point of your examination and another point of your examination. You can start to see where the things don't add up, and you see that pattern. And if you see that pattern, it's tipping you off, right? And there's different ways to look at this, right? So the ways that are omitting facts, that's the most frequent, or committing, which means that you're just basically telling a lie, right? And so the most frequent is people forget to tell you, right? So that's why the records become so important, right? And when people are telling you the truth, right? They just give it over to you, right? But when people are trying to deceive you, then they're trying to twist you and convince you and move you in a certain direction. That's when the flags have to go up, right? How do you detect deviation from norm? Well, there's different ways, and there's actually literature about this. And I've actually been to lectures on this. And so just take a look. Look. First of all, you'll see clusters. People will change their posture. They'll avoid looking you in the eye. They'll perspire. They'll cover part of their face. They'll pick at their clothes. There'll be all kinds of things. There'll be a mismatch. I've had patients come into my office, tell me that they can't sit because of their orthopedic injury, yet they sat in my exam room for 2 hours filling out questionnaires. They sat in my office when I took a history for an hour. And that's not true, right? Next, wait for 3 to 5 seconds. What does that mean? What it means is that when people are trying to deceive you, when people aren't giving you a straight honest answer, ask them a question and then wait after the answer. So say, oh no, it's not true. Wait 3 to 5 seconds. If they start shifting around, looking nervous, picking at things, they're showing you the behaviors of deception. Keep them talking. It leads to inconsistencies. This happens all the time, where you just say, well, tell me about that, right? And they keep going and going, and sooner or later, you start hearing stories, information that's inconsistent, right? Equivocation phrases, right? Increase in the adverbs, right? Using things like, well, if I knew then, what I knew later on, and they're trying to, always kind of shift the history around. Those are the patterns, right? You're going to pick this up in your history. You're going to need to know about this. I'm not saying that you're a psychiatrist, psychologist, or that you're doing a careful investigation. What I'm saying is these are the things that you and I kind of know. We kind of know through all years of training, of seeing patients. We kind of know when we see certain patterns, right? Give them a questionnaire. Look what they document. Look at that behavior. You don't have to come up with the final answer, but you do have to have substantiation for your opinions. I'm trying to protect you so that when you write things in a report, when you give your opinion, if you make somebody unhappy, they're going to come after you, right? They're going to take your deposition. They're going to send you interrogatory. They might put you on trial or something as an expert witness, and you have to be ready for the documentation. Don't let it be, well, I'm so-and-so, and I trained with so-and-so, and I trained with this one. Who cares? Who cares where you train? It's got nothing to do with it. These people have things in their heads. They have agendas. They're looking for money, right? And they might have been injured, and there might be some legitimacy there. But sometimes they take on these other behaviors, which we're talking about. They take on an illness behavior. They take on that symptom magnification. They have a use disorder, which goes above and beyond. And that's what you need to be able to say, identify, articulate, substantiate, and put into the thing. Okay? Deceptive communication. Jacob at the start told me it was Pom Pom Sunday, right? Not Palm Sunday. Okay. All right. So rest stop, right? So what we've done so far, we've talked about the important concept of what could be operating the claim, right? What are those secondary agendas, right? What do you and I know from our training? What have we learned? What have we seen? What is our experience, right? And then to document it, right? Malcolm Gladwell, Think Fast, Think Slow, Common Tversky, System 1, System 2, just the things we're talking about, where you and I are looking at patterns and trying to recognize those patterns. Give them those questionnaires. Let them put it in paper, document it, and it will no longer be about what you say, right? It'll be, here's what the patient shows, right? All right, so that's some of the general questionnaires. Now let's talk about pain questionnaires, okay? Here we go, right? So pain, generally you remember this, of how it's experienced, right? Where people actually have some irritation in nerve ending and they will perceive it. Then they'll have an experience with that, but what comes on with it could be a pain behavior, things that people do, how they change things, right? So let's give them questionnaires and take a look. Okay, so here's one. You ask these questions anyways, right? When did your current problem begin? What did you do first to hurt yourself? Where's the pain problem beginning? Since the beginning, has your pain problem constantly been, right? Those kinds of things, right? And so what is that getting at, right? So you and I know that if somebody has an ankle injury, but then they start saying like, oh yeah, but my shoulder or my elbow, something, that's not connected, right? That's starting to show you some somatization, symptomatization, right? And how many previous episodes have you had, and when are you previously treated, okay? Take a look at this. Look. How many previous episodes of the problem you had? Too many count. Once or twice a month with Richard, right? When you start seeing that kind of result, they're not even giving me a number. My questionnaire says, give me a number. How many previous episodes? They can't even put in a number. They have to write it out. That's already telling you. There is good data that says that if you have a history of multiple past occurrences of the same injury, that is a direct predictor of people who go on to have somatization, delayed recovery, chronicity of illness, right? These people are not going to get better, right? Don't think that you're the greatest doctor in the world. Don't think that it's all based on this current claim, this current injury, right? These things are operating. If you get to a double-digit answer in this, it is virtually a guarantee in the literature. There is no chance that they're going to get better. Certainly, at best, you can get them back to some kind of baseline of misery before. But that's the rules, right? Next, how often does your pain occur? How would you describe your pain? Or how often do you have numbness, right? And give them a questionnaire. Ask them about location, right? So it's the right side, left side, both sides. And how would you describe dull, sharp, aching, dry, impaired, right? Now, this allows you to document their responses, okay? And here's what we get. Here's this dishwasher was stressed out, right? Now look at this, right? Bilateral, head, neck, back, arms, leg. And it's sharp, dull, aching, burning, stabbing, pins and needles. They have their entire body involved in this, right? They have lit up every sensory nerve we got, the C medians, the myelinated, the unmyelinated, you got everything on this one page, right? This one questionnaire. It's telling you that this problem is not in their spine. It's not in their extremities. It's in their mind, right? That's how they see themselves. That's how they're experiencing themselves. That is what their problem is. And it's got nothing to do with the original mechanism of injury. It's got nothing to do with the MRI shows, the EMG shows. It's got nothing to do with that. That's got nothing to do with it. It happens to be how they see themselves, right? Give them a questionnaire. Get this documented. Get it written down, right? Next, look at this. Pain aggravation, right? So tell me, what makes you better? What makes you worse? What has no effect, right? Give them a questionnaire. Here's our dishwasher again. Look this. Worse, 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 worse. Everything makes them worse, right? If you think that this is the kind of person that you're the best doctor in the world, that all your colleagues didn't know what they're doing, that you're going to make them better, that you're going to be able to treat them, that you're going to be able to do surgery on them, and you're going to touch this person, you're nuts. Don't touch them. Don't go near them. Are you kidding? Right? They're telling you on this questionnaire that they are going to be a problem, right? If you tell me that in your entire career, you've never had one patient that you don't regret, right? We said, oh, I saw this patient, I thought it was this, and I said I was going to do this surgery, or I said this was the treatment or something, and then all of a sudden becomes an albatross around your neck, right? This is how you try to pick up some of those people, right? Give them a questionnaire. Let them do it, okay? Next, pain diagrams, right? So pain diagrams, this is originally from Moody Matheson's work, and you can start to see patterns. Once again, I'm asking you, give them a pain questionnaire, right? Give them the pain diagrams. Here's what you're gonna get, right? Here's the stressed out dishwasher. Now look at this, look. You start getting a halo of pain around the head. See this? And diagrams into every part of the body, right? This is not normal, right? Look at this. This is a university administrative analyst. Now look, see, this person has stuff crawling off the hips, right? Stuff coming down the side of the arms and all this kind of stuff. This is not normal, right? They even made sure I saw the dots, every single individual toe. If you see that, this is telling you, this is somatization, symptomification, somatic symptom disorders, right? Cognitive illness. Don't operate on them. Okay, look, here's another one. Look at this, look. Now this is black and white. Doesn't come out completely perfectly, but this is a patient that came in to me. This woman was on long-term disability, had 24-hour nursing help, right? This woman had every imaginable diagnosis you've ever heard of. Now, you're not going to believe this. I'm going to tell you this. You're not going to believe me. You're not going to believe me. Okay, but I'm going to tell you this. She claimed of all of her diagnoses that it also included that she had hypothyroidism and hyperthyroidism at the same time. I mean, it's impossible, right? This woman went up to my staff, right? She took hours to fill this out. She went up to my staff and said, look, do you have color highlighters? Because it's not enough to do X's and O's. I had to understand how the pain was emanating from her body, right? They have blue and pink and yellow, and that's what she filled this in with, right? To let me see how difficult her life was, right? Look at this, right? This is a patient who stopped working at 30 years due to fall. And by the way, this is just a fall to the ground, nothing big, nothing severe. And you see this, this was to tell me that the pain was coming out of the body, right? They were having a California out-of-body experience, right? This is telling you that they're not normal, right? Don't think that you're going to say, well, I'm so-and-so, and I train with so-and-so, and I own a boat. Who cares if you own a boat, right? This has got nothing to do with your boat. It has to do with them. It has to do with their ability to understand who they are, and they don't. They have taken on illness behavior. They have secondary gains. They have other things going on. Give them the questionnaires. Give them the papers. Document it. It'll support your opinions. It'll protect you, right? Next, always ask people about their pain. Now, it's very important, very important. A couple issues here. One, I always ask on my questionnaires to give me a number between 0 and 100, right? Now, there's multiple issues here. One, questionnaires, they usually have the VAS scale. That's where you have a line, you make a mark in the line. But the problem with the VS scales is, first of all, people make Xerox copies of Xerox copies, so those things are always getting wavy and changing over time. Two, you got to spend time measuring the thing. Three, they tend not to be as reliable of an indicator of someone's responses, especially over time, right? Whereas when you ask people to write a number, it's better. Number two, always ask people to rate their pain between 0 and 100. Why? Well, it turns out that if you give people a scale of 1 to 10, right, then as you're treating them or evaluating them or hoping to get them back to work, something like that, and the numbers start going down, what they experience is that there's a loss of their illness. There's a loss of their identity. There's a loss of their ability to be the patient, to be taken care of, to be impaired and hopefully get more money. So they hang on to stuff. By the way, this is also true. I was a lecturer for the National Institute of Health on smoking cessation. It's also true in the smoking literature. Whereas, the people say, well, you got to quit cold turkey. Why do they say that? One of the reasons they say that is because what happens is if you try to cut down and you get down to 1 or 2 cigarettes, those individual cigarettes take on so much value that it's harder for people to let it go, right? And so that's one of the problems with cutting down or doing these numbers. But, so if you have somebody that says, well, my pain is 90, right? You say, well, I'm treating you, how much better are you? Well, I'm 40, right? Because they feel they got a lot of points left. If you give them 1 to 10 and they go 9 and they're down to 4, all of a sudden that 4 seems like it's getting pretty near the end, right? But for you and I, it's the same result, right? We've got about 50% improvement, right? Give them the questionnaire, but get them. Now, look, here's CNA, the woman that was bench pressing the residents. Your pain right now. By the way, in my questionnaires, it says pain of 100 means you have to be hospitalized. These are people who sit in my exam room, people sit in my waiting room, people sit in my office taking the history, put down hundreds, right? Give them a questionnaire. Let it get documented so you know what you're dealing with, right? Look at this one. This is a patient, 47-year-old, who said cleaning cameras hurt his arm. Now look at this. Your typical average pain, severe 100. Severe 100. Oh, it's not enough to say 100. It's not enough to say I need to be hospitalized right now. It's like 100.9. That's all you're going to give me, right? I can give this guy a scale 1 to 1,000. You pick 1,000, right? This is someone who cleaned cameras and it hurt his arms a little. Are you kidding, right? You're going to say that, oh, this person needs a tubular tunnel release. This person needs a carpal tunnel release. Oh, this person's, are you kidding? You're nuts. Don't touch these people, right? They are having a problem. They are seeing themselves in a certain way. This is their limitation, right? You are seeing somebody that have taken on illness behavior, chronicity of illness, delayed recovery, right? They are not going to get better in their current mindset, right? Okay, next. As you remember, we talked at the front end about the biopsychosocial model, okay? So depression, anxiety, that'll do it, right? If somebody's depressed, if somebody's anxious, they're going to have all this symptom reporting, right? And by the way, look. These are only 2 questions. And the reason I did that is because there's a lot of literature. Look at all the literature I put in here for you guys. Look at all this literature. That you can usually ask 2 questions, right? And get about as much discrimination as you need, right? I'm not saying that all these questions, the Becks and all these other big ones, are nothing, right? Okay, that's more in the psychiatric world. But for you and me, trying to get a quick picture, what's operating, what's in somebody's head, right? What's making them tick, right? Ask a couple questions on anxiety and depression. And if they're anxious and depressed, you're going to know what's operating, right? And there's ways that you could look at these questionnaires that let you know that there's literature that supports. Just give them 2 questions. Now somebody say, well, I see in here that you gave him a questionnaire. You only asked 2 questions about depression. Doctor, are you saying my patient's not based on 2 questions? You say, hey, look, I'm not a psychiatrist. I'm not a psychologist. What I'm saying is that it seems like some of these things are operating, which is why, in my professional opinion, I offered the impairment rating and the recommendations for treatment based on all the information here. If the parties want a more definitive answer on this area, then you're welcome to consider colleagues in that field, right? But what it does for you, it protects you. It gets documentation. It lets you see what you're dealing with. It lets you know not to treat these people the same way, right? When I see these things, I don't treat them the same way, right? We know that depression can present as pain, and pain leads to work loss. We know that the sickness preemptive working while being sick can lead to depression. We note that 69% of depressed patients present with somatic symptoms. 47% of the general anxiety disorder patients present with somatic symptoms. They don't come in and say necessarily, I'm depressed. They don't come in necessarily and say, I'm anxious. They come in and say, my back hurts, my shoulder hurts, right? You have to know it's operating. And it's important. This stuff leads to divorce, work loss, suicide, bad things, right? So give them a questionnaire, document it, protect yourself, have that documentation, right? Next, health locus of control, okay? This is a very important concept, okay? This has to do with self-efficacy. Okay, in health locus of control, there are 2 types of people, internals and externals, okay? And internal, right, is the kind of person that's an ideal patient for you and me. These are the kind of people that say, oh yeah, give that to me, I'll take care of it, I understand, I'm on it, right? You say to people, I want you to go see the neurologist, get this MRI, start the physical therapy, come back in 2 weeks. And they're on the phone on the door. I got it, I'm doing it, I'm gonna make myself better, I'm gonna do this. And they come back and say, look, I did this, I exercised myself anyways, and I'm better anyways, right? And so this has an internal locus of control with social support, with the way that they're wired, that they can do well. That's an internal, that's an ideal patient, right? Externals see the world very differently. Externals say, I am not responsible for my health. You are responsible for my health. As a matter of fact, you, the employer, you, the doctor who's examining on behalf of the employer, you should have known better that this job was going to create troubles. You should have known that this injury could happen. You are the one that should be helping me out with this. And by the way, these are the people that will come into your office and say, look, you asked me to take this medicine, didn't do much. You asked me to go for here, didn't do much. The only thing that's helped me is going to the chiropractor or going to the acupuncturist. And you only have me going twice a week or 3 times a week. I want to go 5 times a week. Okay? All right, so what's going on there, right? Multiple things. One, we already know that if they're an external, they don't want to do anything, right? So the chiropractor, a bad chiropractor, is a dream for this, because the chiropractor keeps saying, well, I am the way, I am the way, the light, I am the Lord, just keep coming back to me and I'll keep taking care of you, right? So people like to be taken care of, right? But what are the principles of physical therapy and rehab? We know those principles, right? Posture position, flexibility, aerobic conditioning, and muscle strengthening. Those are the principles that keep people better. There's no question that when a chiropractor moves you, it can feel better. The question is, who's supposed to be moving you? The chiropractor for the rest of your life, or you for yourself, right? And another thing is, there's no question that when you have a chiropractic thing or massage or ultrasound or electrical stimulation or acupuncture, you get an endorphin release. And yeah, it makes you sleepy, it makes you feel better for an hour or 2, right? It doesn't last because you haven't addressed the underlying area. But externals will see this and they'll say, look, this is really going to be a problem unless I continue to get this kind of treatment, right? But the problem's not in their spine. The problem's in their mind, right? The problem is how they're viewing themselves, right? Here's one. Look at this. Look, here's their CNA, right? Extremely anxious, extremely depressed. I have no powers, right? This is the patterns, right? You're going to see, right? Another one. Look at this. Fear, avoidance, belief. Now, Gordon Wallow, who I had the pleasure of knowing, and he wrote one of these questionnaires, the fear, avoidance, belief questionnaire. I took the most discriminating question from this questionnaire, right? And I said, what happens when they say that they have fear, avoidance, belief? They believe that any pain equals injury. Any pain, right, does not lead to anything but trouble. They've never heard no pain, no gain, right? But we all know that's not true. We all know that from an injury, especially surgery, that there's rehabilitation you have to do. You have to strengthen yourself. You have to build yourself back up. You have to improve yourself. We already know that, right? We already know that that's operating, right? So if somebody has high fear, avoidance, belief, right, they're not going to get better. They're not going to participate in their care. They're going to want to go to the passive modalities. They're going to want to lie on tables. They're not going to want to work. But that's not in their best health interest. That's not in healing them, right? Give them a questionnaire. Ask them the question. Which, by the way, I've had this before, where I've given these questionnaires, and I've had people on this stuff where they say, hey, you know what? I actually have these high fear beliefs and all this stuff. So, you know, I had somebody come in, ready for this, ready. So this woman comes in and, you know, puts these records on my desk. And says, you know, Dr. Hyman, I've seen these other doctors, and you know, I have a problem, but I referred to you, and I heard that you're a very good doctor, and I'd like to work with you and try to help this out, and all that kind of stuff. So I want you to see, though, I take this seriously. I've been to 5 different doctors, and I've done all these tests, but I don't want to talk about them because I'm not sure that they're really doctors. But I can tell you are different. I like you. I like your office. I like your staff. They seem very good, very helpful, right? And so what I'd like to do is I'd like to get to the bottom of this, right? And I'd say, so, you know, sorry, wait, what's going on here, right? And I said to her, I said, well, can I look at some of the records? No, because I don't think they do a very good job, right? But I can see you're a good doctor, and I think you could do a good job, right? And then I say, well, okay, you know, what were some of the diagnoses, some of the treatment stuff? Well, they said this, but nothing else, nothing gets better. I don't think that they're right. I don't think they've done a thorough job. Now, it turned out that I got out a little bit about some of the doctors she'd seen who I thought were good docs, right? And so all of a sudden, I get those little hairs raising on the back of my neck, right? And I start getting nervous, right? Because this is going to be somebody that's going to have something's going on there, right? So it turns out this one was a writer. So I said, listen, by the way, I want to ask you in your profession, right? Since you're saying that medicine hasn't been able to help you, in your profession, I've heard that there's this thing called writer's block, right? Where you're working on something and you're trying to write, but you can't quite get past it and you have to do something. And says, that ever happened to you? She goes, no, never happened. Because what you can do with the writer's block is you can actually go get a consultation and identify the script and do this, right? And so, and I don't really want to talk about that. What I want to talk about is whether you're going to be helping, because clearly these other people didn't help me, right? And so what I'm trying to get at is I'm not happy with the care I got and some of that. So all of a sudden you start hearing that, right? So everybody is good or bad. You're with me or you're against me, right? When you start seeing that, right? That is somebody that's starting to display borderline personality disorder. At minimum, borderline traits, right? They see the world as good and bad, yes and no. You're with me, you're against me. And one of their biggest manifestations is anger. They're angry at the doctor, they're angry at the employer, they're angry at the injury, they're angry at everything. If you have one of these types of patients, right, a borderline that sees the world this way, what is the treatment of choice for a borderline? It is probably to get them out of your office, right? And you're going to say, oh my God, that's cruel, Mark. You're a doctor. You're supposed to help people. Treat them, okay? The borderlines may not see your efforts that you're trying to treat them. And unless you're about to tell me that you're an expert in handling borderline personality traits and disorders, I'm telling you, it is going to be fraught with difficulties. You're going to try to apply your same standards. You're going to try to use the same MRI, the same physical exam, it's not going to work. Eventually they're going to blow up because you're going to give some recommendation which seems reasonable based on the literature, and they're going to latch onto it and say that you did not treat them properly, right? By the way, don't think that I'm being a bad doctor. about this, right? Don't think that, because I've had some of these patients and I've tried to refer them to my colleagues for help, my psychiatry colleagues, psychology. I said, oh, Mark, I don't do borderlines. What the heck does that mean? I'm asking you to do them. I'm asking you to treat them, right? And I said, oh, no, I don't do borderlines, right? Because they know how difficult they are to treat, how difficult they are to try to get them to follow a program, to stay within visits, to not call them excessively, to not put blame on them for everything that goes on, right? I've had this happen to me before, right? You first meet a patient, you think like, oh, I really like this person. They got a good personality. We really click, really connect. And then all of a sudden, one day, go south. You're going, what happened there, right? Those are the borderlines, right? These are the people that you can pick up from some of these questionnaires. You got to know about it. Give them a questionnaire, document it, protect yourself, right? Next, job satisfaction. So, doesn't come as a big surprise. If somebody doesn't like their job, they're not going back, right? Give them a questionnaire. So these are the Vermont and APGAR scales. So once again, I took what I thought were the most discriminating questions from the Vermont and APGAR scales and put them together on a questionnaire, right? You know, how much you like your job, how well you get along with fellow employees, and how certain are you going to be back to work within a few months, right? And so what you can do is give them these questionnaires. What are they thinking, right? Take a look. Look at this. Look at this. Please indicate, oh, I love my job. I love my job. No, I'm not going back. You see this? You see this? Love my job, love my job. I'm not going back, right? Give them a questionnaire, right? It's very important, because if you give them the questionnaire, right, they're going to tell you what's really operating there. By the way, I've seen this a lot of times. I've had patients who not even circled zero. They circled not at all certain. They're not even on the page, right? They're not even in the scale, right? They're telling you it's not the mechanism of injury. It doesn't matter what the MRI shows. It doesn't matter what the nerve conduction shows. It doesn't matter who you are. It doesn't matter who you train with. It doesn't matter anything, right? What matters is who they are, how they're perceiving themselves, and what's really going to operate. And you think that you're going to get these people back to work? You think that by doing surgery, you're going to improve them? No chance. That's not where their head's at, right? It's not in their spine, it's in their mind, right? I've had, by the way, this is a true story. I'm going to tell you the story. True story, right? I had a woman that got sent to me with a shoulder injury. She worked at a hotel here in Los Angeles, big hotel. And the human resources person knew me, sent her to me, said, well, you know, she's been in treatment for a few months at this, you know, doc in the box thing, and she's not getting better. Could you take a look at her? So I said, sure. You know, I evaluated, gave her my questionnaires, right? So on this question, she circled a 0. And on her history exam, you know, she'd been cleaning rooms, just housekeeping. So, okay, you can get some shoulder difficulties, but doesn't seem too bad. Her exam wasn't too bad. And I said, well, you know, I don't understand why you don't think you're going to go back to work. She says, well, I don't know. I'm just not sure how my shoulder's going to do. I said, well, okay, you know, I think your shoulder will do fine, but we'll get you in physical therapy. We'll watch it carefully. I called the human resource person. Now, listen to me. Listen. I called the human resource person. I said, your lady doesn't seem like there's a big mechanism. Doesn't seem like she has much exam. But here's what she said. When I asked her, she's going to make work. You know, give me a big 0, right? I don't understand that, right? Because, well, I don't know. I'll try to check out, see if something going on in the work environment. I get a call a few weeks later. This is a true story. True story. Ready? It turned out that the head of housekeeping, her boss, and the assistant head of housekeeping were part of a minority mafia. And they were extracting payments from all the workers to support them. They fired these guys, and then guess what? Her shoulder got better, right? True story. Just let you know what you can pick up sometimes, right? When you have these perceived stresses, there's scales for that. And there's ways to look at that where you can ask them questions about things like this, which can be on a 4-point scale, which is something that maybe you like that better, right? So it's another way you can do that, right? There's a professional scale, quality of life scale, right? We can look at different things that are making you happy. By the way, this is a lot of stuff that's going on to us. Look at this. Look. This is the professional quality of life scale, right? So this has to do, and something that's been applied to a lot of us, right? Where it takes a look at physicians, healthcare providers, frontline workers, right? You hear a lot about that stuff right now, about the stresses of having gone through some of the things we've been going through, right? Or just the nature of our careers, right? There's questionnaires you could do that. If you're seeing somebody that fits into more professional capacity, you can give them this questionnaire, right? And document, what are they thinking? Are they having stress issues operating? Is that determining what they're seeing you for? Because remember, I told you, a lot of these people come not saying I'm stressed or depressed or anxious, but saying my back hurts, my arm hurts, my shoulder hurts, my leg hurts, right? You need to know these things are operating, right? Don't treat them like everybody else, right? Professional quality of life is based on a lot of things, right? It's based on a lot of our impacts with each other, based on the impacts from the different environments, what that can do, and can it lead to compassion, fatigue? Can it lead to exhaustion? Can it lead to depress work environment, right? These are the things that could be operating, right? There's concept of social capital, right? Where how good are we at bonding, bridging, linking, and between different teams, right? When social capital is possible, this leads to a great work environment. When you're getting along well with people, when you are in an environment where everybody supports each other, when you have that, we are social animals. By the way, this comes out a lot of times when we talk about, people working at home, right? There's a lot of stuff, a lot of literature about, how many people like to work at home, like having some control of that, but there's a lot of people, majority, who want to work in a work environment and see other people at least a few days a week. We are social animals. The social capital is important to us. It makes a difference. If they're not happy at their job, they're not going back to work. The determinant of their going back to work has to do with these different domains. And it has to do when it's positive, you're in a good place, right? It has to do with those measures, right? If somebody's not happy at work, they're not going back, right? You've got to know, is this operating, right? Give them a questionnaire, ask them that stuff. Okay, next. Mick Sullivan. Mick Sullivan has some questions. So I've taken a couple of his most discriminating questions, right? This is called the pain catastrophizing score, the PCS, right? When I'm in pain, I worry all the time about whether the pain will end, right? And it gives a scale of 0 to 4, right? Next, the injustice experiences questionnaire, right? Nothing will ever make up for all that I've gone through, right? So what that means is that they're now reporting to you these certain areas of feelings of injustice, right? So they're catastrophizing. And so when people start catastrophizing, they're not getting back to work. They're not going to go and through the normal process. They're not going to report to you the same way. If they feel that this is injustice, right? That this has been a travesty, that the employer should have known. You represent the employer should know. You as a doctor should know, right? And they have a feeling of injustice, then if that's their belief system, they're not going to get better, right? Give them a questionnaire. Ask these questions, right? So, for example, these difficulties can be seen in many papers. This has been described many times. Let me just show you one. Look. This is patient 25 who was a sedentary employee who developed back pain one day sitting at work. Okay, now look. Can people sitting in a chair develop back pain? Yes. Is it the most common mechanism of injury that all of a sudden they have severe back pain from sitting in a chair and then all of a sudden they have scales of 4 on these questions? No chance, right? That's not what's operating here. The pain is not in their spine. There's something about the work environment. There's something about them. There's something about their belief systems. There's something about their illness behavior. There's something about their personality. Something is operating. Give them a questionnaire. Document it. It'll support your opinion. It'll let you know what you're operating with. It'll give you that latitude to be certain about what you're dealing with and why you are or are not recommending certain approaches, right? Now, final psychometrics. If you do somebody with back pain, I like the modified Roll-Morse questionnaire. If you do neck pain, I like the Vertimere neck dismay. So I pack these onto the back of my pain questionnaires. So here's the back questionnaire. Now here's our CNA, right? 23. out of 23 positive, right? This problem is not in the spine. This problem is in their mind, okay? Take a look. Here's another one. Look at this. Look at this. This is the book seller from a well-known company. Look at this. She adds a question to the questionnaire. 23 are not enough. I'm going to give you 24. I'm going to change the questionnaire. I'm going to change the literature. They don't know what they're talking about. I am severe, right? And there's only one time where she says, okay, no, right? When you see this, this is somatization, symptomatification, delayed recovery, chronicity of illness, the DSM-5 criteria of somatic symptom disorders. This is the conversions. This is the borderlines. This is some of the passive aggressive. You can have everything operating here, right? You need to know about it, right? You need to document it. Give them a questionnaire. Have it in your chart. Know what you're relying on when you justify your opinion, right? Look here. Look. This is the Vernon-Muir neck disability, which I give to people, right? So you can start seeing. Look at this. So it goes, remember, it goes 0, 1, 2, 3, 4, 5, right? So 5, 4, 5. Okay, reading, no, don't have problems. 3, right? You start adding these up, you see, oh my gosh, look at this. Everything's so high, right? Look at this. Look. Here's the long-term disability one with both hypothyroid and hyperthyroid. I told you about this lady. Look at her marks, right? Look at this. 4, 5, 4, 5. It's very high. This is not normal. When you have people with this much reporting, it documents what's going on, right? It protects you. It substantiates your opinion. Okay, arrest stop, right? So I want to remind you, because we've been doing a lot. There's a lot of information here, but I'm trying to help you. I'm trying to help protect you and your reporting, your practice. Okay, so a couple things. One, we've talked about the questionnaires. Why do questionnaires? What could be operating? What are some of the general questionnaires and the clues on that history? The job work history. Any of the review systems, all that kind of stuff. Right? Very important. Right? We talked about the pain questionnaires, looking for those patterns. We talked about the personality types. Right? I'm not done, right? I want to show you some more stuff, right? Stay with me on this. Look, an exit questionnaire, okay? This is a questionnaire I give to all the patients when they leave my office, right? You might want to consider doing this also, right? Look at those questions, right? The office personnel were courteous, considerate, explained the exam was thorough. The examination and testing did not harm me. Do you see that question in there? You know why I put that question there. Because have you ever had somebody that comes back and says something you did hurt them? I do this at the time of their exit. I have them fill it out, right? And by the way, I had a lawyer come to take my deposition. The lawyer says, they didn't like my opinion, right? Lawyer comes in, first question, Dr. Hyman, my client says that the process of your examination injured them greatly, and they were greatly distressed by the pain and injury that they went through your office. I pulled out this questionnaire. I showed it to him that there was no indication at all. Depo over, right? Stopped it right there, said, oh, thank you for your time, left. Got it? This helps protect you. Look, even when I showed you all the questionnaires I'm suggesting, all the questionnaires I recommend, right? All the ways to try to evaluate patients, right? I give them this exit questionnaire. Look at this. This is patient SB. This is his 6th workers' compensation claim. I was asked, and I said at the very beginning, you were sent here today to talk about your inguinal hernia. That's all you were sent here for, right? Here we go. Here's the exit questionnaire. 5, everything's great. But I was told at one time that an eczema and psoriasis on my skin, and here's the word over, right? Now we're not done, right? We're not done. Just like some of the other ones, they got to write this on the back. This is an exit questionnaire. They're already leaving my office. I've already done the history, done the exam, any laboratory testing, right? And they're not done. Their illness is their life. They want the attention, right? They want you to understand what they're in. You start seeing those multiple claims, multiple doctors, that's an indication that someone's got somatization, symptomatification, delayed recovery, chronicity of illness. Don't treat them the way you treat anybody else. They're not going to get better. That's not who they are, right? Right. Now, what I've shown you up till now is all these different questionnaires, right? And one of the things that is operating here is coherence analysis. Okay, what does that mean, right? What does that mean? So it means that you see all the C's that I like to call, right? which is where between all these different questionnaires, you're going to see the same types of patterns. You're going to see the same types of responses. It's going to flow through. So the advantage to you is that it gives you a broad base upon which to defend yourself, support your opinion, protect yourself, justify your decisions, right? Because you're going to have this broad base of information, right? So look. You've got all these things operating here, which can influence the result. But most importantly, you're going to see it go through these things. Okay, so here, I'm going to show you an example. Ready? Stay with me. Stay with me. This is very important. Watch. Here, we're going to go through one patient, like all their stuff all at once. Go watch this. Watch. Okay? Patient you, 37-year-old deli clerk, worked at a local supermarket. Initially, she was slipping, fall on the ground. Okay, so she's in the deli. She falls on her butt. That's it. That's all we got. Ready? Here we go. Okay, so everything makes her worse. Kind of difficult on the side to see it, but she's checked off everything in the middle. Here's the pain diagram. So it looks like the Texas Chainsaw Massacre from Texas, right? It's crazy, right? Here's the anxiety, depression, fear, avoidance, belief, right? Here's love my job. Look. Circles, not all sorted, not even on the scale, right? Here's the modified Roland-Morris questionnaire. Here's the Vernon-Muir neck dysmetrics, right? You see it again. It flows through that coherence analysis where you see the continuity of everything flowing through the different questionnaires, right? You see that pattern. So somebody can't come and say, well, you just gave him a Vernon-Muir neck dysmetrics. Is that the only thing that's out there? No, right? I did the FABQ, I did the Vermont, I did the APGAR, I did the modified Roland-Morris, I did the California pain diagrams, right? So this starts to substantiate your report. It looks like a credible report. It looks like substantial medical evidence. It's going to protect you in your decisions, right? It's going to help you justify your ratings, right? Okay, look at this, right? Here's another one. Stay with me, okay? 46-year-old woman who was pushing a tray of food, slipped and fell forward. It was only soft tissue injured. Her exam had frequent exhaling, grimacing when I did the otoscope in her ears, abdominal tenderness that disappeared when I used the stethoscope. So in other words, I put my hands there, oh. I said, oh, good, I'm going to listen to your abdomen. I put the stethoscope, I could mash all the way down the kidney. She didn't move, right? These are non-physiologic findings, right? Let's take a look at our questionnaires, okay? Well, here we go. First of all, sorry. Here you go. Look. Right side, left side. Look, you got all the different nerve endings going on, right? It's constant. It's severe. I have constant numbness, right? Everything makes me worse, right? Let's take a look at the pain diagrams. Okay, here we go. California out-of-body experience, right? Everything's going on, right? Let's take a look. How certain are you going to be back at work? 0. And look at those Sullivan questions, right? All the time. I think about this all the time. I know I'm not going to get better, right? That's the pattern. Let's look at your modified Roland-Morris questionnaire, right? Let's look at the Vernon-Muir neck dysmetrics. See it? Look at those numbers. See, 4, 5, 4, 5, right? Okay. So look, now I've shown you a couple of these things. I've shown you them in detail. You're starting to see the pattern. You're starting to see what happens, right? So I'm going to show you somebody else. I'm not going to tell you anything about them, right? I want you to look at these things very carefully because you're starting to go. I'm starting to get you. I'm getting you from system 2 to system 1, where you and I, who were trained in medicine, and we know how to recognize patterns, we're now learning to recognize these patterns on paper, to document things, right? So let's take a look, okay? So here we go. I'm gonna give you some time. Okay, here we go. Ready? Okay. Take a look, right? So you see, here's the descriptions. Okay, frequent, slight. Here's them. Some things make better, some things worse, no effect, right? Got it? See the pattern? Okay, do the next one. Here's the California pain diagram. Got it? So you see this over here, a little over here, this, got it? Okay. Continuing. Your pain right now, 40. Average mean 50. We're 65. Anxiety, depression, health low to control, fear, avoidance, belief at about a 6, right? Here's the modified Roland-Morris questionnaire, right? So maybe half and half, right? Fair? Now, I'm showing this example so you can see that pattern. And also you're saying, well, geez, Mark, you know, you showed me these other examples. Everything's so severe, so severe. This one doesn't look as bad, right? So you start thinking, well, maybe that's a little more credible. But who was this patient? This patient played for the wide receiver in the NFL for 13 years. That's what normal looks like, right? A wide receiver in the NFL. Do you know the forces that these people go through and the pounding their bodies take, right? That's why it's so extreme, so severe, so difficult, right? And yet, this is the normal responses, right? So it gives you an idea. These questionnaires work, right? They help guide you, okay? All right. We're encouraging people to become involved in their own rescue. I've told you about this. Really important. You got to get people taking care of themselves. You got to get them from that external locus of control to internal locus of control, right? It is much more important to know what sort of patient has a disease than what sort of disease the patient has. That's Osler, 1600, right? Maimonides. Just as body humors influence man's virtues, so too do virtues influence their humors. If that doesn't go back far enough for you, Aristotle, the treatment part should never be undertaken without considering a whole person at the era of our day. Look at that, our day, right? Aristotle, our day, right? Right? Hyman says, not Simon said, treatment spine, treatment line, in all cultures, rituals are important. We talked about the importance of culture. We talked about the importance of social capital and all those kind of things. And that's it. Okay, so these are the boys. And I'm going to exit out of the slideshow just so that I can give a whole human being here. And then this is the time where you and I can open this up for questions, right? And so what I want to do is I want to get first of all, there's one thing in the chat, but feel free. Good news about these. Good news about the breakout sessions. They're very small, so we can get to big people. So we've talked about the questionnaires. We've talked about the importance of having this documentation for yourselves. We've talked about how this can be important for you and how it can help you in understanding what you need to think about, what you need to consider, how you have to incorporate this into your reporting to substantiate your opinion, to protect yourself so that you can hopefully do well. So I'm open for questions from everybody. I know it's a lot of material, but I'm happy to take questions if anybody has any for everything that we covered today. We good? Yes? Okay. Fantastic. All right. I hope this was helpful for you. I hope that you got something that you could really use in your practice. And that if you have any questions about the questionnaires, about what they mean or how they apply, you can certainly always contact me, and it'll help you in what you're trying to do with the patient. I wish you all the very best. Everybody should have good health, and let me know if you need anything. Thanks so much.
All right, I'm going to stop recording.